So, one of the reasons that we say that we love to do SCAN FYI is that it gives me the opportunity to introduce the community, all of my viewers out there, to a new service or maybe a new medical specialty that you might not be familiar with. Or I might not even be familiar with it. And today, you're going to meet a doctor who's a urogynecologist. And if you're like me, you never even heard of that before. And you certainly don't know, why would I ever need to go to a urogynecologist? Well, you're going to find out why. So if you want to know more, please just stay tuned. Good morning, everyone, and welcome to SCAN FYI. Yeah, we have a doctor today that I am not at all familiar with, and I'm guessing a lot of you are not familiar. My guest this morning is Dr. Christopher Iwanoff. Good morning.
Good morning, Andrea. Good morning, everyone. Thank you.
Well, thanks for being with me. And you know what? Let's just start out by having you introduce yourself and explain what is a urogynecologist, because I have a feeling that many people like me are absolutely not familiar.
Yeah, you're absolutely right. I meet a lot of women, my patients that don't know, didn't even know that we as a specialty exists. So, my name is Christopher Iwanoff. I am a subspecialist urogynecologist and reproductive or reconstructive pelvic surgeon. Urogynecology is a subspecialty of OBGYN. So, I did an OBGYN residency after medical school, and then did an additional almost 4 years, 3.5 years of a fellowship, which is specialty training in just urogynecology and reconstruction pelvic surgery, just focusing on women. Now, this could also be accomplished through a urology track where there's a urology residency, and then you can do the subspecialty of female pelvic medicine and reconstructive surgery or urogynecology and reconstructive surgery. Both of them train for approximately 7 years in total. So we do four
Long
years.
time. Yeah.
Yeah, so 4 years of OBGYN and then 3 years of the urogynecology fellowship. Whereas urology will do 5 years of urology and then 2 years of urogynecology or of the urogynecology and reconstructive pelvic surgery. I think the difference specifically between the two different tracks is that throughout our entire 7 years, we've been dealing and treating and managing patients that are strictly women. Whereas urology for the first 5 years is really predominantly a vast majority are going to be male patients, so prostate disease and those type of stonework, a lot more, I would say a lot less specific to just women's healthcare. And that can be, something that differentiates us as a urogynecologist from an OBGYN track versus a female urologist or a urology, female pelvic medicine or urogynecologist from a urology track. Nevertheless, I've met great physicians and great surgeons through both tracks. So, but it gives you a distinction. So I'm not a urologist per se. I don't deal with stones. I don't deal with kidney disease, strictly lower urinary tract. So, for example, urinary tract infections, we
Right.
deal with urinary incontinence, we deal with hypersensitivity disorders such as what we call interstitial cystitis or bladder pain syndrome. We deal with sexual dysfunction, so pain with intercourse. We deal with pelvic organ prolapse, and we also deal with fecal incontinence, or what we would call anal incontinence, so loss of stool, liquid stool, gas, those type of problems as well. And to be quite honest with you, a vast majority of women who have one of those problems will have multiple problems. So we're dealing and asking about those, all of those conditions to make sure that we're treating your entire pelvic floor, not just the one issue. So
Oh,
that,
if you're a typical woman like me and you were not the least bit familiar with yours, that a doctor of this specialty existed, I wonder how we would have. I mean, here I feel like I'm introducing you to a whole audience here. I just wonder, why don't more people know about this?
yeah, that's a great question. I think a lot of women and men, because we all have embarrassing problems. It's not something that we're talking to with our friends or our family. It's not something we're saying, hey, I have, a vaginal bulge or I'm leaking urine or I'm leaking stool. These can be sometimes socially, embarrassing. And so
Yeah.
or uncomfortable to talk about. And so I think a lot of women don't have that outlet to talk to their friends. and see, if they did experience or if they are experiencing it, who are they going to have those things treated or managed? Um, and I think, bringing those conversations up with your primary care provider is the first step. And when we talk to primary care providers, our colleagues in family medicine or internal medicine, or even our OBGYN colleagues, we make sure that they are always asking the questions I'm going to ask is, do you
Right.
have any urine? And so if you don't ask the question, you don't know, and then you can't get that person to the right person, doctor to treat that. Do you have any accidents with bowel movements? Do you feel like there's any vaginal bulge? Are you sexually active? And if you are you having pain? So those are just basic questions that will lead us down a track of what may be going on and how can we help you.
So ideally, if you were to share some of these issues with your primary care provider, they would ideally say, oh, this is really not my area. You need to see a urogynecologist.
Correct. Yeah, yeah. Part of the, I would say, challenge is also knowing that or having primary care providers that know that they're urogynecologists, right? So just because
Right.
we're in the medical field, they don't know that, a urogynecologist may see this. There's plenty of times where we get referrals for urology type, problems that should have been directed their way versus a urogynecologist, or sometimes we get general GYN problems that should be going to the obstetrician gynecologist. But I say for a vast majority of OBGYNs and primary care providers, they do know about our specialty, and will direct you, appropriately.
I think of all the times at SCAN where we've had doctors come in and practitioners come in, and just for example, talk about incontinence, which is, it's a common problem. So we understand that, but never once did I ever hear anyone mention a urogynecologist. It's just fascinating to me. But
Well,
now what I hope I'm doing is raising awareness for lots of people who might have some of these issues that you mentioned and honestly just didn't know where to go.
I will say there is a history of primary care providers and OBGYNs that would be dismissive of those complaints. So, oh, you're leaking a
Yeah.
little, you're getting older, it's normal, you have to live with it.
I'm not surprised to hear you say that because I want to say old age is not really the diagnosis here. Yeah.
No, and I will say this, is it common to have urinary incontinence, whether it's urgency, frequency, can't make it to the bathroom, which we call overactive bladder, or stress incontinence, leaking with coughing, laughing, or sneezing, or a vaginal bulge, which we would associate with pelvic organ prolapse? Yes, it's common, but it's not normal. It's not what we should accept. And so if it's something that is bothering you, I would recommend you see somebody, a specialist like myself, to have it evaluated. Now, I will always tell a patient, let me make you comfortable and understand that all of these conditions are not life-threatening. It's not something that's going to make you have heart disease or diabetes or dementia or, you name it. It's
Good to
something that
know.
it's
Yeah.
something that's going to improve, affect your quality of life. And if it
Yeah.
affects your quality of life, if you're running to the bathroom all the time and you can't do anything because you're always in the bathroom, if you're always uncomfortable because you have a lower pelvic pressure and vaginal bulge and it just bothers you, then I would do something about it, to make your quality of life better. And we have one life, right? And
Yeah,
so
and I think again, a lot of people, I have experienced myself dismissive doctors, so and I'm sure many out there have as well, for me, that's a sign to change doctors. That's my feeling. But for many of the things that you're talking about, is it a surgical option to take care of these things, or are there other kinds of options that are non-surgical,
yeah, that's
minimally invasive? What are we
That's a
looking at?
great question. That is a great question. Yeah, I think a lot of people, when they first come and see us and they refer for their doctor, they're expecting that they have to have surgery.
Yeah.
And is not the case. Not the case at all. So when I always talk to patients about their options after we do an exam and make sure we're offering a consultative treatment plan that it's appropriate, for what they originally presented for. It's going to start with do nothing. Again, if you just wanted to know, hey, I have pressure down there and I just want to make sure it's not something that's going to affect my health and I want to know what it is, and you're okay with that and it doesn't bother you, it's not affecting your quality of life, then my recommendation is always going to be just come back and see me once a year. Let's make sure that it's not getting any worse or you're
Okay.
not having anything, changing those symptoms that you want to now deal with. If it is bothering you, then let's talk about conservative management, either with, pelvic floor physical therapy, which is a special physical therapist that deals with those pelvic floor muscles. And your pelvic floor is made of three specific muscles. We have the pubococcygeus, the puborectalis, and the iliococcygeus muscles, which really forms that floor of the pelvis. It attaches to bones in the pelvis and kind of creates this pelvic floor outlet, supporting all of your bladder, your rectum, your uterus, and keeps that in place. And
Yeah, which is
there's
pretty important, by the way. Yeah.
and connective tissue, dense connective tissue also doing some of the support there too. Um, but there are physical therapists that focus on those muscles and help you exercise those muscles that can make those symptoms either improve, resolve, or at least make them somewhat better. You know, if that's not enough, you could always try other in-office procedures, and then there's surgical options. But there's not one thing that I would recommend to you or to anybody else because each and every person is an individual. So we talk about those options, and ultimately you're in the driver's seat and you get to make the decision what fits your lifestyle and what's going to meet your treatment goals.
I think sometimes that people are hesitant to go further than their primary care doctor because they worry that it's right away going to be surgery and they don't want to go there. And I guess surgery is always an option if other conservative treatments don't work. But
You're
yeah.
right. And we have all flavors, right? So we have all who they don't want to do anything but surgery. They're like, this is bothering me. I want it fixed because there are success rates compared, for surgical options that are much more higher success rates versus conservative options. But again, it's all about meeting your treatment goals. If you say, you know what, I just want a little bit less incontinence, or I just want to make myself feel a little bit less pressure, I want to start with pelvic floor physical therapy or a pessary. And that may be a term that your audience doesn't know, but it's just a plastic or a rubber or silicone device that helps push up the prolapse that's fitted to your body. Um, and if those things meet your treatment goals and you're happy with it, but it's not 100% perfect, then that's the right treatment for you. However, there are, again, women who's like, I can't use any of those things. I don't want to go to physical therapy. I'm willing, to explore surgical options. Well, that's the right answer for them. And then we talk about all those surgical options in detail. Myself and my partners all have, consultations before surgery where we examine and explore all those options, give you the success rates, the failure rates, the complications, what to expect post-operatively, what to expect perioperatively, like the day of surgery, the day after surgery.
Right.
How long are you going to be out of, work, or how long are you not going to be able to do the normal things that you would like to do? Like if you're a pickleball player, how long can I not play pickleball? Or if I'm going to the gym, how long can I not go to the gym? If I'm a swimmer, can I swim right after? We answer all those questions. And I will say for a vast majority of what we do surgically, it's about a 6 week period where you're not doing that pickleball or the yoga or swimming. The activity is going to be what you would normally do around the house. You can take care of yourself. You can shower. Can't take baths or sit in pools of water, but you can do the normal things to take care of
Okay.
yourself. You just can't go above and beyond until that surgery completely heals.
If you have to invest 6 weeks in healing and your lifestyle is much improved, I would say, wow, I think that's a pretty good deal.
Yeah, and so you say to
Yeah.
yourself, what is the trade-off? If I'm really
Hmm.
uncomfortable and I'm not doing those things right now anyway because of what I'm experiencing, whether it's incontinence or pelvic organ prolapse or fecal incontinence, then you might say this is a no-brainer for me, and I'm going to look forward to having a potential resolution of all of these symptoms and be happier 6 weeks later, maybe 8 weeks later.
Curious, I always say, look, old age is not a diagnosis, but are many of the issues that you see people for, is some of it related to just you're getting older?
So that's a great question itself. Now, when we're talking about, let's say, stress urinary incontinence, which is leaking with coughing, laughing, or sneezing, as opposed to overactive bladder, which is leaking, or urgency, frequency, waking up at night multiple times to go to the bathroom, not making it to the bathroom in time, sticking that key in the door when you get home and you're like, oh, I got to run to the bathroom. Those are all signs of overactive bladder, two different mechanisms. Now, we usually see the stress urinary incontinence, and pelvic organ prolapse is another one. Um, but we usually see the stress urinary incontinence in your 40s because, women, well, let me go over, back it up a little bit. Stress urinary incontinence, pelvic organ prolapse are significantly increased or have an increased risk factor when you have vaginal deliveries or just having babies in general. Now, I
Yeah.
will also say as we get older, our tissues, those support ligaments and dense connective tissues, those muscles get weaker. And so now you're also at risk for pelvic organ prolapse and urinary incontinence. And so those two combined, with age will put you at a higher risk. So is getting older just a reason to have these conditions? No, but it's a risk factor, if
Okay.
that makes sense. And there's other things too that put you at risk, certain connective tissue disorders, certain neurological diseases, if somebody has Parkinson's disease, if somebody has Alzheimer's disease or dementia, if somebody has multiple sclerosis, those are all risk factors for the overactive bladder. If somebody's had, like I said, children, getting older,
Right.
chronic constipation, being obese, those are all risk factors for stress urinary incontinence and pelvic organ prolapse, you know.
So I think the best news of all, though, my biggest takeaway is none of this is life-threatening, which is a
That's it.
good thing,
Exactly.
which is very important. Don't be that concerned about it. And that suddenly we're finding out that there is a doctor who actually specializes in all these things that we didn't even know that there was. So that's the biggest bonus of all here today.
And what I,
Dr. Iwanoff, I'm so appreciative of you being with me today that we could share this with people who I'm sure, like me, had no idea.
yeah, I'm happy to be here.
Well, all of Dr. Iwanoff's info, his contact info, be in all the show notes. And, again, really good to know that it's not life-threatening and it's not, I mean, I don't want to say it's normal, but it's common. It's
That's
typical.
great. Yeah, these are all common conditions,
Yeah.
but again, it's not normal. It's not normal to leak on
Not
yourself.
normal, not
Yeah.
normal. But there's help. There is definitely help for all of us. So that is a great thing. Thank you so much for being my guest today.
Oh, you're very welcome.
So remember out there, if it's important to you, it's important to us. I'm Andrea Tarr. We'll see you next time on SCAN FYI. Bye, everyone, and bye, Dr. Ivanov.
Take care.